Hello! I vividly remember a moment a couple of years ago when Janae and I were saying, are we really going to do this? Are we really going to move our family overseas to do medical missions? And we said, let's do it. Let's live the adventure. Well, several years later, here we are. We've had our first few weeks in Papua New Guinea, and I want to take some time to share about what our first few weeks in Papua New Guinea have been like, especially the medical care that I have been doing in the hospital. Just a disclaimer, some of the stories and images may be sensitive for younger viewers, so parents may want to watch this first before including the younger ones. On my first day in the hospital, I was nervous and excited. I was following along Dr. Ben, who is the main general surgeon for the hospital as well as the director of medical services for the hospital. We saw lots and lots and lots of patients in the outpatient surgery clinic. That first week in the hospital was really an orientation week for me, where I got to see all of the different things that the hospital did, from caring for patients with tuberculosis to their HIV clinic, to their antenatal clinic, to pediatric ward, to adult medical ward, to all of the surgical wards. That first week I spent some time in the nursery where we care for the youngest babies that are born in the hospital, the smallest babies.
Thank you.
Some of these babies are only a kilo or two, just a few pounds, and the hospital provides them with oxygen and warmth and nutrition as these little ones are fighting for a chance at life. We spent time caring for and praying for the mothers of these little ones as well, as they go through that difficult and long journey of hoping that their little one will start to gain weight and be able to live.
Hello. Hey, cutie.
I also got the chance to assist in 2 cesarean sections back to back, which is certainly something that is not in my job description as an emergency physician back in the United States, but a wonderful thing to get to learn and to get to be a part of. The hospital here at Kujep also has created and has relationships with multiple rural community health clinics where they can provide care in remote villages. And the first week we were here, I had a chance to go visit one of those clinics, which was doing screening for antenatal moms to try to give them the best shot of having a healthy delivery. I brought along with me a portable ultrasound, and I was doing some ultrasound for these mothers to show them their babies, something that I suspect has never been done in the village before. So that second week in the hospital, I was rounding in the morning on our pediatric ward where all of the kids who need care are admitted to the hospital. That first day on the pediatric ward, I teared up about halfway through rounds. In one bed, there was a young 3-year-old boy who had been diagnosed at the hospital with ALL, or acute lymphocytic leukemia, which is a type of blood cancer. Now, in the United States, if a kid has ALL, there's almost a 90% cure rate for ALL. However, in Papua New Guinea, there is nowhere in the entire country of Papua New Guinea that has chemotherapy and treatment for ALL, so ALL is essentially a death sentence. So I looked at this little 3-year-old boy, I thought of Milo, thought of the fact that if he was in the United States, he could potentially be cured of this, but here in Papua New Guinea, he was receiving palliative care and blood transfusions, but there was no shot that this cancer would be cured. Right next to him, there was another young boy that I'll call Daniel. And Daniel, like many kids in the pediatric ward, was admitted for severe acute malnutrition, essentially admitted for starvation. He wasn't getting enough nutrition, and he wasn't getting the right kinds of nutrition. And so I saw this little boy who was curled up in the fetal position in his mother's arms, and he's just whimpering and moaning, and he looked so incredibly miserable. His whole body was swollen up and edematous. His feet were edematous. His face was edematous. His scrotum was edematous. And his skin was peeling and sloughing off. All of these things are sequelae of severe malnutrition. One of the bad things about malnutrition is that it causes all of the organs to fail. And malnutrition causes the gut itself to atrophy, and it makes it where the gut can't absorb nutrition like it should. So the very nutrition that a child needs can't be properly absorbed because of the severe malnutrition. Now, one of the other doctors that I was working with said, what's going to happen most likely for Daniel is that in a few days, we are going to come in and the staff is going to tell us that he has died overnight. He's passed away overnight, that he is so far along in the severe malnutrition that his likelihood of survival is very, very low. And so halfway through the rounds, I teared up thinking about these two kids next to each other. One with a cancer that could be curable in the United States, another starving from lack of nutrition. That second day when I rounded in the pediatric ward, I spent some time just praying for Daniel, praying for his mother. He was heavy on my heart. And I know I shared with Janae about Daniel and his condition, and she prayed for him and had some friends back home start to pray for Daniel as well. Every day when I went onto the pediatric ward, Daniel remarkably started to look a little bit better.
He's doing well. We were worried about him, but he's still here.
I remember the third day I went in and he wasn't whimpering and moaning and crying and quite so pitiful as he had been a few days before. He looked around and he seemed a little bit more alert. The next day I went in and some of the swelling was starting to go down in his hands and in his feet as he was receiving medications to help treat his malnutrition and as he was receiving a lot of prayers. The next day I went in and Daniel, remarkably, he had a little bowl of food that he was holding and he was looking around trying to eat a little bit of food.
Good. Looking better.
And amazingly, miraculously, every day he seemed to do a little bit better. And after a couple of weeks of being in the hospital, he was able to lose enough of the fluid and to gain enough weight and to get his appetite back to the point that he was able to be discharged home safely to be able to follow up in our outpatient clinic. Daniel certainly would have died were it not for the care that the hospital was able to provide and for all of the prayers of the staff and the other folks who were thinking about him, praying for him, and caring for him. Every day after spending some time rounding on patients in the hospital, I would go down to the outpatient clinic. And in the outpatient clinic, I would see a bunch of outpatients. I'd also go over to the emergency department if there were patients coming into the ER who needed care. There were so many different unique medical pathologies that I saw in the outpatient clinic and in the ER, things very different than what I would care for in the United States. Many things that I knew very little about that I had to ask other doctors again and again, what do we do for X, Y, or Z? I saw a woman with an enormous neck goiter or an enlarged thyroid, something called endemic goiter, which is secondary to iodine deficiency. I saw people who had chops from machetes. I saw lots of people who had fractured bones that needed to be reduced or put back into alignment and casted. Lots of people who had bad abscesses or infections that we would drain and start on antibiotics. There was one boy that had this big swollen foot that I thought was probably an abscess, but when I cut in, there wasn't any pus or purulence that came out, and it very likely is a tumor that he had in his foot, and so he'll be going to surgery later this week. My first day on call, I cared for a young lady who had a ruptured ectopic pregnancy and she was bleeding into her belly, and she went off to receive a life-saving emergency surgery. I saw lots of patients with HIV or tuberculosis, some with miliary tuberculosis. Tuberculosis spread throughout the body. One of the things that's rewarding here that I don't get to do as an emergency room doctor in the United States is see somebody through their entire treatment course. And sometimes here I'll get to see a patient in clinic or in the ER, admit them to the hospital, care for them in the hospital, discharge them from the hospital, and then follow them out in outpatient clinic. One of the highlights from my first few weeks here was getting to do that very thing with a young baby. I remember I came into the ER and there was this 7-month-old baby that was just struggling to breathe because of a pneumonia. They were breathing quickly, had a high fever, they were needing oxygen, they looked really ill. So in the emergency department, we started her on antibiotics, admitted her to the pediatric ward. I rounded on her every day in the pediatric ward and saw her make a little bit of progress each day to the point that she started to breathe better. The oxygen was able to come off. Mom was just happier and happier every day, and we eventually were able to discharge the patient home. Then I had the joy of this past week at getting to see this chunky, healthy, happy little baby follow up in clinic. Hello? Hello? How are you? There's signs all throughout the hospital that say, "We treat, Jesus heals." And it's a joy to be able to be part of a hospital that has that mission and has that vision. Always good to gather to pray. We just want to say thank you so much for everyone who has been praying for us. And if you want to continue to follow along our medical missions journey, you can subscribe to this YouTube channel or you can subscribe to our blog. If you feel so inclined, we're so grateful for anyone who partners with us financially, and there's information about donating on our website, which is www.morrisfamilymissions.org. Thanks a lot for your prayers. Thanks a lot for all of your love and encouragement. Goodbye.